Dear Konstantin, dear ladies and gentlemen, it's a pleasure to present here some data on treatment success with hepatitis C virus triple therapy with a special perspective of our German view, and also to give you some of my personal experience we have with triple therapy so far. And this would be also in a way case-based, so to be most practical as possible. But Konstantin mentioned the overall problem and burden of hepatitis C virus infection, and starting my talk, I would really like to remind you that probably we have underestimated, at least in the Western countries, and as you can see here in the US, the importance of hepatitis C virus infection. So as you can see from this slide, during the last 10 years, the population-based mortality in the US with respect to hepatitis B virus infection was nearly identical. And HIV-induced mortality decreased over time. But in the same time, there was a significant, nearly doubled increase in hepatitis C virus-related mortality. So this clearly shows that hepatitis C virus infection is a very significant disease. It takes a long time until the complication occur, but because most of the infection were done or people were infected 30 years ago, now we see more and more these problems, and it's estimated that within the next year a further increase in hepatitis C virus-induced mortality will be seen. Well, on the other hand, and you have heard a lot about treatment efficacy, and this is just a reminder showing you the current treatment success we have, and that is even more to come within the next year. So in a way, you can tell your patient it's more a matter of time whether you're cured, but in most patients, even now, we have the weapons in order to induce a sustained response. And you see, even in the pre-treated situation, in the treatment-naive situation, most patients can be cured. And quite interestingly, even in the null responder patients, you have now sustained response rate being not far from the response rate we have seen so far with dual therapy in treatment-naive patients. So it's clear, we have effective treatment, but how will these effective treatments alter the population-based risk mortality? And I think this is a very important point to consider, because the reduction in population-based complication and mortality not only depends on the effectivity of your drug, it mainly depends on the rate you are treating patients. And this is connected and correlated to your screening efforts, that you know how many people are infected in your country and had access to treatment. And these are type of models done in Europe in order to show what will be the impact of a more potent treatment on the reduction of disease-related mortality, and what would be the impact if you have a broader access and a higher screening rate of the infection. And I would like to show you the data here, and it depends from country to country, depending on the screening strategies you have in these different countries. And for instance, in France, everyone where a blood sample is taken, in a general physician, private practice, will also have a hepatitis C virus and B virus testing, so the screening rate is quite high, whereas in other countries like here in Italy or UK, the screening rate is quite low. And if you have access, or only a limited percentage of all people being infected have access to treatment, you will see, like here in UK, the impact of having higher sustained response rate on the overall reduction of mortality is not very significant. But if you improve access rate by screening patients, this will have a huge impact if you have then very active treatments where you can cure most patients. Well, Treatment access is one thing, then it's tolerability of the disease and what are evolution of current available direct antiviral treatments with triple therapy. And I think there are two improvements I would like to discuss. The one is shortening treatment duration, and we had a brief discussion yesterday on that, and I would like to show you a case also discussing whether we can shorten in some situation the treatment duration. And on the other hand, and this can be an important point also for adherence and tolerability of the current regimen, whether you can reduce the dosing frequency. And at least in Germany and in Europe, it's now approved that a 2-time daily tenofovir regimen is as effective and approved for treating patients with tenofovir triple therapy. So some physicians are not really sure whether it's really as effective if you have not the 3 times dosing every 8 hours, just a 2-time dosing with 3 tablets. And therefore I would like to show you some data really to convince you that is really an alternative and can be used in our patient. This is the overall sustained response rate, seeing if you have a 3 times every 8-hour dosing or a 12-hourly dosing, and you see overall identical response rate. But what about the more difficult to treat patient? Is it better to have, for let's say, a cirrhotic patient, a more every 8-hour dosing instead of a lower dosing frequency? But again, you see here different subtypes. Those with mild fibrosis, advanced fibrosis, no cirrhosis, cirrhosis. And this is always a twice daily and thrice daily dosing. And overall, there's an impression that even the 2-time daily dosing is equal or even a little better than the thrice dosing. And a reason could be that adherence to treatment may matter. And as you can see here, if you have only a 2-time dosing, adherence, and this was really fully adherence, more than 95% of pills taken, is significantly higher if you have only a 2-time as compared to a 3-time dosing. And if you are fully adherent, as shown here, you have a very high adherence rate, more than 95%, then you have you have some advantage also with respect to the SVR rate. So for me personally, and I think this is more or less the situation in Germany, so we completely switched our regimen. Now it's licensed from the 3 times to the 2 times daily, and I clearly have the impression that it had a huge impact on adherence, because my impression was that especially the night dose at midnight, taking food with this 20-gram fat was not well tolerated, not very well perceived by the patients, and they quite often missed it or had not enough food or fat intake to have proper resorption of the drug. Well, I would like to start with one case presentation, and you may consider this as a kind of an easy-to-treat situation. And what I would like to discuss is whether we should treat this patient, whether we need dual therapy or triple therapy in this so-called easy-to-treat situation. So it's a 50-year-old female. She's a hard-working woman. She's self-employed, had a big company, but had some stress in her life because she was divorced. She's a single parent, and due to that, some sleep disturbances, some depression, and this medication here. She was diagnosed not many years ago, in 2007, was treatment naive, and you see a favorable genotype with the EL28BCC. We have a fibroscan, no liver biopsy, but a fibroscan of 8, that's not an advanced fibrosis, that's for sure, probably an F1 or F2 situation, but a high viral load in a genotype 1b. Hypothyroidism, low vitamin. I'm not sure whether you're measuring vitamin D. I always do it. There are now data showing that many of the patients with Hep C have significant vitamin D deficiency. and some data that vitamin D deficiency has a negative impact on treatment outcome. But in any case, you have to supplement vitamin D if it's quite low. So, would you treat this patient? Clearly no advanced disease, it's 50 years old, and we changed our guidelines quite recently in 2010, and they are still, with respect to the indications, the same. Our older guidelines, it was treatment indication mainly for those with more advanced fibrosis, with an F2 situation, but now it changed that we feel that treatment is basically recommended in any patient with chronic hepatitis C. Clearly we have to respect side effects, so there are intolerant patients. This must be taken into account, but nevertheless also showing the data that if you start earlier, the chance for cure is higher. This was the rationale to have this recommendation. So according to German guidelines, here is indication for treatment. The second point we may ask, is it an indication for triple therapy? Or can we use dual therapy? Because this patient had an interleukin 28b CC genotype, so it's most likely to respond also to interferon and ribavirin. And here I would like to show you the overall recommendation we have in Europe, and you may see from this slide that they slightly differ. In most countries, as in our country, in Germany, it's clear that for genotype 1 infected patient, triple therapy is a primary treatment option. But we also consider dual therapy in certain situations, and we consider dual therapy when the chance to have an abbreviated treatment regimen for only 24 weeks with dual therapy with a very high rate of success and cure is high, and this is especially if you have no advanced fibrosis, if you have a CC genotype, and if you have a rapid response after 4 weeks of dual therapy. So this we can discuss with the patient. You see, in other countries, fibrosis matters, and in some countries, triple therapy is mainly recommended for those with advanced fibrosis. But I'm not really in favor of this concept, because even with triple therapy, you see an effect on fibrosis stage, on treatment success, and as you can see here, highest success rate in those with mildest disease. So you may imagine that hepatitis C therapy is in a way also a prophylactic treatment in order to avoid severe complication, and as soon as you start, the higher the chance for cure, and there's, with increasing fibrosis stages, a reduction in the chance of achieving an SVR. Well, in our case, this patient had a very high viral load. And if you have a high viral load, at least in Germany, we have the guideline, even if you have a rapid response on dual therapy, don't abbreviate your treatment regimen because the risk of relapse is higher. So you have to go for 1 year dual therapy. Therefore, in our hands, a clear indication for this patient for triple therapy. And you see here the 2 different regimens you may choose for this patient. So what happened? We started treatment. There was a very nice response, as you can expect, for a CC genotype, treatment-naive patient. Already at week 2, a 5-log decline. Week 4, undetectable levels on triple therapy, and anemia developed. Patient suffered from an urinary tract infection, had not really a rash, but had really a big problem with itching, and I would like to come later on this point, some sleep disturbances. But overall, the patient was very much afraid for all these side effects, but treatment, according to her, was much better tolerated than expected. But what happened then? After 12 weeks, we can stop the PI, and we hoped itching would be better and all the side effects, anemia, and so would become better. And indeed, there was an increase in hemoglobin level. But what happened then when the patient presented 4 weeks later after stopping Teleprevir, that the overall situation became worse. And it started to have a kind of a loss of concentration, a paresthesia, sleep disturbances, so a kind of neurologic, neuropsychiatric side effects, a kind of this interferon neuropsychiatric syndrome I'm much afraid of. And this is typical in females, and sometimes it takes a very, very long time until patients recover from these interferon-related side effects. There were also hair loss, weight loss, you see here, and itching did not improve, although Teleprevir was stopped. So it was not easy for this patient to take the medication, to go to work and all these things. And this was a time when we were aware of this data showing that probably we can abbreviate treatment duration in CC-infected patients from the concise study I presented yesterday, that in those patients being treatment naive and relapsers without cirrhosis having favorable genotypes, that a 12-week treatment duration may lead to very high sustained response rate. So I discussed the data with the patient, and because there was no improvement in side effects, we decided to stop treatment. And I was especially concerned about this loss of concentration, this paresthesia that occurred. But you see, we stopped it, and the patient is still in sustained remission, so he was cured with an abbreviated regimen. So to summarize some key learning from this slide, if you have an easy-to-treat patient with a low viral load where 24 weeks of dual therapy can be quite successful, I think you can consider dual therapy in this situation. And this is also driven by this lead-in concept if you have a rapid response. And if not, you can add a PI at this stage. However, as I've shown you, even in this situation, triple therapy in mild disease is more effective overall and gives a chance for the future to reduce treatment duration, although this label is not in the label yet and it's not approved in Germany. But I think this is really a good option for the future. I would like to come to the second case, and this is a case Professor Buck will present to you, especially discussing the lot of co-medications this patient has and how to deal with drug-drug interaction. And I would like to show you the patient mainly to discuss side effects that might occur during the antiviral treatment. So we have a male patient, and this patient is being a relapser and had a more advanced disease, as you can see here, NF3, an unfavorable viral genotype with a subtype 1A, and some comorbidities and taking a lot of drugs. I wouldn't like to mention it at this stage because you will hear more about that in the next talk. Well, there's no doubt that this is a relapse patient, more advanced fibrosis, and these are the recommended regimens for these prior relapse patients. And you know that the chance for cure in the relapse patient situation is quite high. So treatment was started, and what happened, what we can see quite often, is again anemia. You heard a lot about anemia management during these days, and to remind you, anemia starts early on triple therapy, but mainly beyond week 2. It's not what you would expect at week 1 or at week 2, but it starts at week 3, 4, and the highest anemia rates were seen between week 4 and week 8. And you see how there are certain risk factors or baseline characteristic associated with anemia development, and being of female gender is a risk. Having a lower GFR or higher creatinine levels, and also advanced fibrosis, patients are at higher risk of developing anemia, and you see that may occur in up to 60% of female patients. It's quite interesting that you can predict already at week 2 who is going to develop significant anemia defined as a hemoglobin level less than 10. And it's not the drop in hemoglobin levels, so whether it's 2 or 3 grams per deciliter, you see a decline early on treatment. It's more the absolute level of hemoglobin you reach after 2 weeks of treatment that may help to guide you who is going to develop levels below 10. So as you can see here, a summary of data, the risk of developing anemia defined as less than 10 grams per deciliter is highest in those having hemoglobin level at week 2 less than 12. It's in the range of 60 to 80%. If you still have high levels at week 2, then the chance of developing anemia is quite low. Anemia is mostly handled by ribavirin dose reduction, and there's overall the impression that the dose reduction has no impact on SVR. And I think this clearly holds true for the relapser patient, where really there is a very high chance for cure, as you have seen, and really no impact whether you have to reduce the dose or not. And even in the partial responders, we do not see a significant effect. I think we do not have good data for null responder patients because the numbers of patients so far being evaluated is limited, but you see here a great variation, so we're not completely sure that in null responder patients the situation might be a little bit different. And I think the similar situation with respect to timing of ribavirin dose reduction. Overall, our general speaking is no effect of the timing of ribavirin dose reduction with respect to SVR likelihood. But if you look quite closely to the data, I think, again, with respect to quite early reduction of ribavirin, we do not have really robust data to give advice, but at least if you start at week 4, then we have a huge database to say everything beyond week 4 seems to be quite safe and do not impact SVR rates. And I mentioned yesterday this recent study presented at the EASL meeting, and in a way I believe in this data, again showing also with respect to early response pattern. If you have dose reduction in a pre-treated patient with advanced fibrosis and you reduce the dose between week 4 and 12, this has no impact with respect to early complete response. But if dose was reduced quite early on treatment, before week 4, you see a difference in the rate of complete virologic response. And this was especially seen in the null responder patient, where the difference was 44% complete response at week 12 in comparison to 75%. So I'm not so sure whether in those being more difficult to treat, null responder patient, advanced fibrosis is as safe to reduce the ribavirin dose quite early. And there's also another very interesting point in the study. It's that in those patients not developing anemia, defined as 12 grams per deciliter, the complete response rate was lower. So in a way, you need a high ribavirin doses, and this is reflected by some anemia, and this can be especially relevant for the more advanced fibrotic patients having a null response. EPO is normally not used in Germany. I think we do not really have convincing data that it had any impact on the SVR rate, and even if you use EPO, a significant percentage of patients require dose reduction. Again, a kind of a summary of this case. You have seen that anemia occurs more frequently and more rapidly with triple therapy than with PEG-RIBA alone. It should be managed with sizable and timely ribavirin dose reduction, and use of EPO differs from country to country. We normally do not use EPO, and in my hands, if you start EPO late on treatment, if the patient develops significant anemia, the effect of EPO is also quite limited. With respect to ribavirin dose reduction, I mentioned that overall dose reduction does not impact SVR with tenofovir and boceprevir. However, an appropriate initial dosing is quite important, especially in patients with poor response predictors. And although it's off-label, my personal management of those patients being null responder patient not developing anemia at week 2 or 3 or 4 on treatment, I sometimes increase the dose of ribavirin in order to induce some anemia and to have a better response. But this is off-label discussion. Well, this patient also developed rash, and you know that when tenofovir becomes licensed, most of the physicians were very much afraid of the rash situation. But it was quite rapidly clear that anemia was the most problem we had with our patient, and rash occurs quite rarely. This type of very severe rash we have seen very rarely in our patient. Well, skin reactions are common, and for me a bigger problem than this type of rash you can see here, and that can be quite easily treated with corticosteroids, with topical corticosteroids, it's really the itching. And the itching can be quite treatment refractory. However, you have to be aware of these sometimes severe side effects of this severe rash, and especially the patient has to be informed. And normally I see the patients within the first 8 weeks, every 2 weeks, in order to have really a close follow-up of these signs. And the patient must be clearly informed if there is some rash, if the rash is not only on very spotty on the skin, then the patient had to visit again, and you have to look at and to decide whether tenofovir have to be stopped or not. Some few words on whether data from clinical trial may also be seen and translate to what we see in this called real-world situation. And you see we have now really a huge database on real-world data around the world. It's not only in the US, with now more than 1,400 patients treated with triple therapy in early access programs or in non-interventional studies. We have the early access program in European countries with more than 600 patients. You have heard a lot of the CUPIC data, and we have German non-interventional studies after the approval of tenofovir, overall more than 1,000 patients included. And I would like to briefly show you that overall the baseline characteristics of these, it's difficult to see. This is a German cohort as compared to the approval trials are quite similar, with one exception, and I mentioned it yesterday, that we mostly treatment experience. Clearly show you that we already know our patients, and a bigger number of treatment-experienced patients was put on triple therapy as compared to treatment-naive situation. Well, the efficacy is, in a way, if you like, overwhelming and even seemed to be better than what we have seen in clinical trials. We do not have so far sustained virologic response rates because of timing, but we have complete virologic response rate at week 4 and week 12 to present, and as you can see here, regardless whether it's treatment-naive or treatment-experienced patients, 90% achieve a complete response at week 12. And 73 and 76 of the treatment-naive and treatment-experienced fulfill criteria for shortening treatment duration when they are relapsers or treatment-naive. Well, I would like to come to the situation of the cirrhotic patient, and this is just a slide to remind you that cirrhosis is probably not cirrhosis, and patient populations included by cirrhosis might be quite different, and you see the different percentages of people being enrolled in these clinical trials with cirrhosis in the approval trials and in the real-world data. CUPIC was restricted to patients with advanced fibrosis and cirrhosis. And you have heard that a child A does not really reflect the clinical situation of the patient, and you may have a child A situation where you have portal hypertension, and this is clearly a risk factor for side effects. You have seen response data from the CUPIC cohort, and you have to keep in mind that on the one hand in CUPIC you have a 100% cirrhotic population. On the other hand, these are mostly relapser patients. So in a way, from a biological point of view, more easy to treat patient and a low number of non-responder patients. So again, the on-treatment response rate were really impressive in this cirrhotic population. And you see increasing over time with boceprevir, starting earlier because of the not leading concept with tenofovir. At the end, similar number of patients achieving complete response at week 24, but there is a significant relapse rate, as I also already mentioned yesterday, in patients with cirrhotic we have to be aware of. So you might be quite enthusiastic in the beginning, but you have to inform the patient that even if you have a complete response, the risk of relapse is high. And if you see the numbers for the week 4 response on tenofovir and the week 8 response on tenofovir, this is more or less the number of patients achieving an SVR. So rapid response, again, is a very important prerequisite. Well, I would like to come to an end just to remind you that really we have learned from Kupik, and I think it is really a quite simple guideline we can adopt to our clinical management, that patients showing both signs of portal hypertension as reflected by low platelet levels due to hypersplenism and some signs of liver insufficiency with a low albumin level, and if these two factors come together, don't treat them in a standard situation. This is something for specialist centers because the chance of severe side effects and even death in some situation is significant. However, I also would like to show you that our early experience with cirrhotic patients in Germany is really quite different from what have been seen with Kupik. Probably we're now more aware of these side effects and have a closer follow-up of our patients. And you see in our hands the SAE, severe adverse event rate, was quite similar as seen in the realized study, but overall the on-treatment response rate were lower because we have more patients with being non-responder or null responder with cirrhosis. I would like to come to an end with the last case, and I cannot really solve the problem here, but this is a situation we are quite often confronted with, also being working in a transplant center, that we have these patients with more advanced disease with a clear urgent need of antiviral treatment. You see here a 50-year-old, so a young male being self-employed as a photographer. He had a null response to twice treatment of PEC and RIBA therapy, unfavorable subtype, high viral load, fibroscan, clearly showing that there's liver cirrhosis, and unfavorable genes with a TT genotype, ALT levels, bilirubin is normal, albumin levels were also normal, but he had a platelet count of less than 50. So clear, this patient is not anymore in the label of any of the treatment options we have. He had varices, type 1, 2, and large spleen, but no ascites. So we have the problem that this is a young patient, and if we don't cure them, the chance that this patient will need to get transplanted within the next years is quite high, and also the risk for hepatocellular carcinoma is very significant in this patient, and alpha-fetoprotein levels is already slightly elevated. We know that if we treat patients with these more advanced disease, and if we are able to induce a cure, we reduce HCC rate, not to zero, but we reduce it significantly, and we can prevent further decompensation in these patients and hereby improving overall survival. The problem is we need long-term treatment for these patients. Cirrhotic patients need 1 year of interferon treatment, and we know that patients are not really tolerant to this type of treatment, and the chance that there will be a clinical decompensation if we treat with an interferon-based therapy is quite high if you have a more advanced cirrhosis, reaching from former studies up to 60%. So what I would like to discuss in this situation, that this treatment indication and outcome in these null responder patients with cirrhosis, that overall the risk of treatment failure and resistant development is quite high. And we are not sure whether really doing something good, having this unfavorable interleukin 28B, high viral load, subtype 1A, a null response and a cirrhosis, really to start treating this patient, because the chance that we will end up with resistant is very high. The second point is with this low platelet, hypersplenism, signs of portal hypertension, the risk of severe side effect and sepsis is very high. On the other hand, we have a group here with the highest need for antiviral treatment. We may consider how we can increase in specialized centers here efficacy and improve treatment outcome, and by considering starting with growth factors from the beginning. We need this appropriate dosing adherence and probably starting with higher ribavirin levels. In any case, you need a very close monitoring. Sometimes I see these patients weekly, and we already discussed whether preemptive antibiotics is a good way to start with. I'm not really in favor of this type of prophylactic treatment, but what I always do if I start treatment in the patients with liver cirrhosis, I give them a prescription with antibiotics so they do have it at home. I inform the patient, even it's Friday night, if Saturday, if you have fever, take the antibiotics, come back immediately, and we can check. Don't wait for sepsis. Well, I think that's what I would like to discuss, and some perspectives from Germany, how we treat and we deal with the problems and success we have